Ladies and gentlemen, we now move ahead with the first guest lecture of WCCPCI 2012 that will feature the role of angiotensin-receptor blockers in the spectrum of cardiovascular disease. This morning, our invited speaker is Dr. Saumitra Ray from Kolkata. Before we hand over the proceedings, may I invite our chairpersons. Please welcome in the order of appearance Drs. P. Murthy, Navneet Goyal, Navjot Sidhu and Sukumar Mukherjee. We'll have 15 minutes for Dr. Ray's lecture, followed by 3 minutes of discussion. May I invite our chairpersons to kindly in turn invite our speaker. Dr. Goyal, if you could please join us. Thank you.
I would like to invite Dr. Saumitra Ray to please start with the speech.
Good morning. Thank you, respected delegates, respected chairpersons, all dignitaries, and my friends. My topic today is role of angiotensin-aldosterone system, which is called the RAS system, is involved throughout the cardiovascular continuum, starting from the risk factor modification of diabetes, hypertension, all the way down to death and intractable heart failure. Now, to know this system very simply, we can tell that angiotensinogen is converted to angiotensin 1 by renin, that is the predominant pathway. And angiotensin 1 is converted to angiotensin 2 by an enzyme called S, that is the predominant pathway. And this angiotensin 2 is the active product which works on two receptors primarily, that is called AT1 and AT2. But if you see the slides right and left, there are alternative pathways which I don't want to go into details because of lack of time, which is called tissue system, specific system, ACE independent system, circulating renin-angiotensin system, and ACE-dependent pathways, which also affect the bradykinin. They have their share of physiological and pharmacological and pathological role in disease processes. We know the current potential target is the AT1 receptor. When we called ARB, blocker means AT1 receptor blocker, because that works on the aldosterone pathway. But there are other receptors called AT2, AT3, AT4 receptors, as well as angiotensin 1/7, 1/9, and this kind of receptors as well. Their full role is not clearly elucidated, but perhaps they play also very important role in our physiology. ARBs are receptor antagonists that block type AT1 receptor. These receptors are coupled to the GQ protein and IP3 signal transduction pathway, and that's how they stimulate the vascular smooth muscle contraction. So they're basically vasoconstrictors. So ARBs are basically vasodilators. In contrast to the ACE inhibitors, ARB therapy actually results in an increase in angiotensin 2 level in the body, which is freely available to bind the AT2 receptor or other subtype receptor. That is a very fundamental difference between ACE inhibitor and ARB. And activation of this AT2 receptor might mediate some beneficial actions which are not clearly known at the moment. ARBs evolved in the cardiovascular continuum from blood pressure to stroke to heart failure to kidney disease to diabetic control and ultimately to ischemic heart disease. ARBs have the following actions which are very similar to ACE inhibitors. They reduce preload and afterload. They downregulate sympathetic system. They promote renal excretion of sodium and water, and they inhibit cardiac and vascular remodeling. If we come to hypertension, we know the necessity is the mother of invention. So why after all these years, when ACE inhibitors were discovered in 1980s, ARBs came 10 years later? Because we are not happy with the scenario at that time with antihypertensives. We are still not happy, but maybe a little less unhappy because of the ARBs are there. And if you see the ESC, ESH as well as the American guidelines, almost every indication where ACE inhibitor is first line drug, ARB is accompanying, almost everywhere. There is a special role of ARB in pre-hypertension, and there was a very interesting study done called Trophy trial. If you see, the trial of prevention of hypertension, Candesartan was used against placebo in pre-hypertensive patient, And what was the outcome? The outcome was after 2 years, significant difference in the onset of hypertension. Over 4 years, nearly 2/3 of the placebo group developed hypertension requiring treatment. In patients with pre-hypertension, 2 years of treatment with ARB causes substantially suppressed development of stage 1 hypertension during the 2 years. I think that's a very humdrum statement, and any child can say, okay, you are giving an antihypertensive, blood pressure won't develop. What's so big about it? Why do publish it at all? They published it because of the second line. It is a substantially prolonged the hypertension-free period throughout the trial and delayed the onset of stage 1 hypertension for up to 2 years after discontinuation of treatment. So the concept came whether there is a pharmacological memory in the body, and maybe an exciting concept will come in next 10 years, whether to treat all patients for 1 month with antihypertensive every year just to prevent the onset of hypertension for next 50 years. I do not know. Maybe that is the future. But that is just a brooding concept. In the LIFE trial, losartan versus atenolol on cardiovascular mortality and morbidity in hypertension with LVH, and we see everywhere excepting the myocardial infarction, where obviously beta blocker has got no competitor, ARB is better than all other antihypertensives. And the mortality, you see there is a significant difference in mortality. If we keep this study, atenolol versus ARB, vis-a-vis atenolol versus captopril, ACE inhibitor in diabetic population in UKPDS, and everybody knows that in diabetes ACE inhibitor is a drug of choice. What did we find? There is no difference between atenolol and captopril. There is no difference in atenolol and captopril in 7 parameters they have studied. There is no difference. But there was difference between the same atenolol against ARB. So if we extrapolate, maybe ARB and ACE inhibitor, ARB may be superior. I am again using the term maybe because we have got no head-to-head data. Kyoto study from Japan was sort of an eye-opener. There was a Valsartan therapy reduced the risk of CV outcome when added to conventional therapy, and there was a 45% reduction of event and cardiovascular mortality, stroke, and very importantly 50% reduction of angina. With ARB there was 50% reduction of anginal episode, which was the real hallmark of the trial. And the collaboration study with about 17,000 patients showed that ARB versus comparator, ARB is actually had got an edge on all the parameters of cardiovascular spectrum. What about coronary artery disease? We know the controversy is very, very hot. The issue of whether A2 receptor antagonist slightly increases the risk of MI is uncertain. Some studies suggest ARB can increase the risk of MI in 2006, and that's how the debate came. However, other studies have found ARB do not increase the risk of MI. To date, with no consensus on whether ARB have a tendency to increase the risk of MI, further investigations are needed. You see, in the Valiant trial, at least we have proved that in post-MI patients with heart failure, ARB is as good as ACE inhibitor. Valsartan is as good as captopril in all the parameters we studied. Risk of MI with ARB versus ACE inhibitor is a very, very interesting slide published in 2005. Other active drugs and placebo. What we found in 11 major ARB trial, ARB versus ACE inhibitor, ARB is better. Better in what parameter? To reduce the risk of MI. And ARB versus active drug, ARB is not better. Why? Because beta blocker was the comparator. We cannot compare beta blocker with anything else for heart attack. But for ACE inhibitor and ARB, ARB has got an edge. So that is the paradox of the paradox. High-risk hypertensive patients in Kyoto trial showed 50% reduction of event rate with Valsartan versus non-ARB. And the GK trial, it was a surprise. Effect of Valsartan is Japanese hypertensive patient with proved coronary artery disease. And they found if you have coronary artery disease, role of ARB is much more emphatic than if you don't have coronary artery disease. So if anything, give ARB to proved coronary artery disease patients. That's their conclusion. It's not my conclusion or not the international conclusion. And you see, even in this GK trial, there is 47% reduction for heart failure, but 65% reduction for angina. So ARB is getting better in angina rather than in heart failure. So the coin is turning and tossing. Left ventricular mass index may be the key of this explanation, because no other antihypertensive reduces left ventricular mass or left ventricular hypertrophy as ARBs do. In the heart failure segment, we know the VALHEP trial proved Valsartan is far better than placebo in reducing the events in heart failure patients. 44% reduction of myocardial infarction and death, and it was a very emphatic trial. What happened in CHARM trial? CHARM had 3 wings. Alternative, when ACE inhibitor you cannot give, you give ARB, and very much proof that mortality is reduced, hospitalization is reduced. CHARM added, you add ARB on ACE inhibitor, and there also you reap some benefit, though this issue has become controversial now. CHARM preserved. That means when there is diastolic dysfunction, here ARB have got no benefit in mortality, but again they have got benefit in hospitalization for heart failure. So ARBs is not as that bad as diastolic heart failure as well. And you see, this is very interesting. ARB demonstrate the improvement in left ventricular mass index is the highest. Much better than ACE inhibitor, calcium antagonist, beta blocker and diuretic. In stroke, we have got plenty of evidence that ARBs do help in stroke prevention, also in the Kyoto study. And the value study said that amlodipine was better than ARB. Actually not. Maybe in first 6 months, because amlodipine reduces blood pressure quickly, but down the road for 3 years they are the same. All the values are on the midline. Actually there is some interesting agenda that which lead to A2 receptor stimulation, like ARB, diuretic and calcium blocker, seem to be consistently more beneficial than for stroke reduction than agents which do not have that action. In high risk population, all of us know that ONTARGET trial showed that ARBs are not inferior to ACE inhibitor, and all the curves march one to other. In renal protection also we know that ARB is proved out and out a very good drug, particularly in type 2 diabetes. New onset diabetes and ARB. What is the status? Status is ARB is very good as an antihypertensive in preventing new onset diabetes. And if you see, ARB is the best drug among all antihypertensives to prevent new onset diabetes, even better than ACE inhibitor. This was published in 2007. In atrial fibrillation, ARB is somewhat good to prevent recurrent episodes of fibrillation in case of paroxysmal AF. And friends, there is no dearth of data with ARB in cardiovascular outcome. 57,000 patients on Valsartan, 53,000 patients on Telmisartan, 25,000 patients on Losartan, 37,000 patients on Candesartan. What else do we need to prove a point? Tolerability. Here ARB really scores far above ACE inhibitors. Look at this. Discontinuation. Discontinuation is significantly less with ARB compared to Ramipril in ONTARGET trial. So what is the point of having a good drug if it cannot be continued? So let's rather compromise a drug which is maybe as good and is much more tolerated. That's just common sense. And if you see, ARBs are associated with higher adherence rate compared to any other antihypertensives. Just look at this slide from 2007. They have got the highest continuation rate because they are very innocuous in your body. And there was a concern about cancer, sir. In 2006 it came. Patients assigned to receive ARBs had significantly increased risk of new cancer occurrence. But among specific solid organ cancers, only lung cancers were high. No difference in cancer mortality. And given the 5-6 years limited data, do you think a cancer develops and kills within that time period? These findings, if anything, needs further scrutinization. Even in ONTARGET and TRANSCEND trials do not corroborate to our view. A latent meta-analysis by FDA of 31 randomized control trial published in June 2011, just a year ago, compared ARB to other treatment, found no evidence of an increased risk of new cancer, cancer death, breast cancer, lung cancer or prostate cancer in patients receiving ARB. So I hope this issue will be settled sooner or later in favor of ARB. So sirs, in summary, landmark studies confirm RAS inhibition as cornerstone of modern CV therapy and prevention. In general, ARBs appear as effective as ACE inhibitors in all these settings. In general, ARBs are better tolerated than ACE inhibitors. Thank you for your profound attention.
Thank you, Dr. Saumitra Ray, for the outstanding presentation on ARBs in spectrum CVDs. Before asking one or two questions, is there any preference of role of any particular drug in starting this in prevention of CVDs or control over the CVDs?
You mean
ideal drug?
Ideal drug?
Among ARBs.
Among all ARBs. I don't think, sir, there is one ideal drug among ARBs, but most of trials are based on losartan in the older days, telmisartan in the newer days, and candesartan have got good evidence about stroke. But valsartan is the best valued and best studied as far as heart failure segment is concerned. So if you ask me to choose one sartan among all for whole cardiovascular spectrum, I would rather give my vote to valsartan in 2012. Maybe it will change in 2014, I do not know.
Thank you. Any questions, one or from audience?
Yeah.
It's a class effect, or will you use a particular drug?
That's $1 million
Suppose you are
question.
managing an ACS-like situation, AMI-like situation. Would you like to use a particular drug, or it's a class effect? Because the maximum number of prescriptions are with telmisartan today, as on even losartan.
Yes, sir. All the acute MI setup or acute coronary syndrome setup studies have been done with valsartan and a few with losartan. There is no study with telmisartan or olmesartan. So if I go by evidence-based medicine, I should stick to valsartan. But all the recommendations, Europe, America, China, Australia, in their recommendation, they never mention a particular drug. They always go by class. And this question was asked in many times in international forums. The guideline makers have no answer for that. They said we go by class. But in your individual practice, we should go by that particular trial which was done in that setup. I think that makes sense.
As we have two more orations before the inauguration, so we'll close this session and thank Saumitra for one of the very, very simple and elucidating talk.
Thank you, sir.
Thank you, thank you.
Ladies and gentlemen, as a mark of respect for the lecture being delivered by Professor Ray, he'll be presented with a scroll. May I request our chairpersons to kindly step forward and present him with the scroll in accordance. Thank you, gentlemen, and thank you, Professor Ray, for being part of the proceedings.